Hey, it's Derek Glenn again. We're just doing a little drainage here today. This lady has sepsis. She's got a septic joint here at the sternoclavicular junction, and she's got an abscess which is tracked down behind her sternum. She's not very well, and at the age of 71, the cardiothoracic guys are not particularly interested in her, so they've asked us if we can get a drain into this collection behind the sternum. The plan today, therefore, is to see if we can put just one of our standard 8 French drains into this space in here. What I'm proposing to do is to come in from an oblique approach. We've got the internal mammary artery and vein here, which obviously we need to avoid. We'll be able to see those under Fluoro CT. I'll angle up from below, so a steep angling up approach from below, oblique, come in just behind the sternum there, and then pop the wire into that space. And then run a couple of dilators and then park a little 8 French self-retaining drain just in here. Obviously the issues here are that we will then have our little drain immediately in front of the ascending aorta, so we've got to be careful about that. I'll endeavour to keep the drain down here with a tiny amount of padding between the aorta and the inferior extent of the abscess. We want looking for dependent drainage. We don't want to be up the top here. In terms of alternate pathways, the possibilities here are you could ask for mediastinoscopy. Again, this lady's clinical condition is such that nobody seems to be very keen on that idea. Alternatively, you could do a sternotomy, and obviously that would probably be pretty disastrous. So what we're aiming for here therapeutically is to get rid of the pus to assist the antibiotics before this lady succumbs from mediastinitis. Hi, we're just lining up now for this case. We've got the patient supine. We're proposing to come in somewhere down here, parasternal. We're about to have a look on the Fluoro CT where that exactly is going to be. First order of the day, however, now that we're in position, we've got consent, is to give some sedation. We're going to open the bidding here with 50 micrograms fentanyl, 2.5 milligrams of midazolam IV. Okay, let's have some zoom. We're coming in from patient's left, and we need more zoom, more dose. Let's take that up to, say, 40, and we're going retrosternal. So tube current 40 MA for a half-second exposure, and I'm just working out in my head what approach is going to get us to where we want to go. We need to come in here between sternum and the internal mammary arteries, aiming up from below, quite flat, so that we can pop a guide wire into this space. I need to come underneath that rib. Okay. So we just have the usual setup here for Fluoro CT, sterile cover over the controls. I use the wrap from the prep pack just to function as a sterile handle. Pick up a bit of betadine, and away we go. Local anaesthetic. Going to be using lignocaine 1% today in the usual fashion. So a combination of fentanyl, midazolam, and lignocaine 1% should get us across the line for a relatively straightforward procedure like this. Switch on the laser, bit of skin prep. We've got pulse oximetry and blood pressure monitoring, intermittent blood pressure monitoring here. We're not doing ECG monitoring. We don't normally ECG monitor for a case like this, even in this location. We'd have a problem with the ECG leads as is. So a bit of skin prep, a bit of drape, and then start with the local anaesthetic needle to work out exactly what trajectory is going to work here today. This is the drain we're using, which is an 8 French self-retaining drain. It's a very straightforward device, the usual thing we use for most collections. most collections are thin enough to go down an 8 French drain. You don't need anything thicker. Comes with a stilette, which we remove. This is going to be Seldinger technique, so we're going to put the needle in first, followed by the guide wire, followed by some dilators, and then place the actual drain itself. So job number 1, however, is local anaesthetic. Okay, standing by for team time out. Just the first tap of the pedal there. I'm laying the local anaesthetic needle across the skin here, having a think about what trajectory is going to work to get to where we want to go today. We're going to have to go a little bit more lateral. We need a very flat trajectory to get up into the sternum, and we're going to be angling up from below. Okay, that's good. Just putting some local anaesthetic in now. We're starting to see the trajectory of the local anaesthetic needle. My hand is out of the beam. Probably still a bit too low with my starting point at that point, so I've just adapted my starting point slightly. See that local anaesthetic needle appearing. So infiltrating that area with local. So we're now ready to start placing the needle. This is the trickiest part of today's procedure. Having chosen a trajectory, now our mission is to make it all happen. Coming in quite steep. It's got a wider window. Take it out to about 1500. About 1500. Okay. So my hand is out of the beam here. Okay, let's take that back to 700. You can see I've clearly got room to move with respect to the internal mammary vessels. I'm just a bit too steep at this point. Just need to walk that needle around the edge of the sternum and then angle up. And bring that now down a bit more flat. Okay, we've got the needle now parked behind the sternum, angling up towards where we want to go. What we're going to do now is just a trial of placement of the guide wire. This is the soft guide wire. It's a Benson wire, soft tip. We'll see where that runs. Okay, so we're just swapping up for the 8 French dilator. Hands below the beam. See what's going on there. It's all looking good. And now the moment of truth. So we can actually get the drain to follow where we need it to go today. Get the drain to inch past the back edge of the sternum there. You can see our drain now running towards the area we want, so we'll just rely on the guide wire now to assist the drain to run up to where we want to go. You can see the drain is starting to form up following the guide wire in the collection behind the sternum. Just very carefully easing drain in and wire and stiffener out. You can see the drain there. So we need to get this drain looped around. Get enough of the drain in to actually do the job. Just unlatch the table. Okay, I'm not quite happy with that. We need to put a bit more drain in. What we're going to do is just reintroduce a bit of guide wire and a bit of stiffener and just push the drain a little bit further in. Rather blood-stained parallel material. Okay, so we're done. We've got our drain where we want it to be. The technical issue here was that the geometry of getting the drain past the edge of the sternum was problematic, and I needed to re-site the central stiffener because the drain didn't have enough mechanical strength to continue to feed past that sternal edge, so I needed to put the stiffener back in. Putting a stiffener back in down these drains is always tricky because it tends to snag on the draw wire inside the drain, but we've got the drain now where we want it to be.